Hello and welcome to Bifurcation Continuum 2023. Following European Society Congress of Cardiology, in which 3 important randomized studies dedicated to use of imaging in contemporary PCI practice were presented, we wanted to see what is the impact on left main and bifurcation stenting. So for that reason, we dedicated our first bifurcation webinar, left main and bifurcation stenting optimized by intracoronary imaging. My name is Goran Stankovic, and I have 2 great colleagues and friends, Nicolas Amabile and Jacek Legutko, to discuss the contemporary aspects of use of imaging for left main PCI. So we invited you to attend this webinar to understand how to use intracoronary imaging in clinical decision-making of coronary bifurcation treatment, to learn how to use imaging to select tools and devices for left main and non-left main bifurcation PCI, to understand how to react to imaging to optimize the result of bifurcation PCI, and to discuss when and how to use IVUS versus OCT imaging during left main and bifurcation PCI. I would like to invite you to use the chat box and send your questions. We will be very happy to discuss and try to answer absolutely any question you may related to use of imaging in left main PCI. And now I hand over to my friend Nicolas to present the first case.
Thank you, Goran. Good evening to everybody. Let me first, so it's a great pleasure to be here, and I will present you a case of step-by-step OCT-guided left main PCI. So the case is for a 59-year-old man who is referred for coronary angiography because of the exploration of hypokinetic cardiomyopathy. His cardiovascular risk factors are represented by diabetes, and he has also medical history of significant peripheral artery disease. The transthoracic echo shows a very depressed left ventricle function with ejection fraction around 20 to 25%, with apical akinesia and lateral hypokinesia, no mitral regurgitation. Let me introduce you his coronary angio on the left of the left coronary, and we see that there is a multivessel disease with some kind of diffuse disease, especially on the distal part of the left main. We also notice a complete total occlusion of the mid-LAD with a respected, well-developed first diagonal branch. And the spider view on the right panel shows you probably it's less pejorative with compared to cranial view, but there's still some very distal left main with a potential trifurcation. So this kind of complex bifurcation. And the right coronary artery also presents some stenosis with a diffuse disease. So in order to guide our strategy, we decide to go for cardiac MRI in order to assess the presence of any viable myocardium in the anterior wall. And we're quite surprised that there was no viable myocardium on the anterior and the apical walls. So it means that the occlusion of the LAD did not make sense. However, at this point, and based on the angio, it's still, I think, interesting to discuss the potential options with Goran and Jacek.
Thank you, Nicolas, for selecting such interesting and complex patient to present today. Of course, it's my privilege to ask Jacek, one of the most experienced interventionists that I know, to share with us your view on this clinical indication and then potential revascularization strategy.
Thank you very much, Goran, and good afternoon, everybody. I believe that it is really very interesting and educational case that Nicola is presenting now. First of all, we need to stress it is high-risk patient and with low ejection fraction, and at the same time high-risk PCI because we need to deal with the distal left main. However, in my opinion, we can try to make it as simple as possible. So it means provisional strategy by angiography would be my preferred option. However, to do it safely and optimally, which is very important for such patient, I would guide this with intravascular imaging.
Yeah, thank you, Jacek. I think we should go to our smart board because I try to share my view on this geographic appearance of disease. Because for an interventionist, I think angiography is our GPS.
Yeah.
And there are two projections that I selected, apicaudal and apicranial. And what I see, I try to draw here, it's actually more diffuse pattern of disease inside the left main and in front of the ostium of the circ. And what we know is that plaque distribution is usually in the lateral wall of bifurcation opposite to carina. So carina is usually free of disease. And if we look here, does not seem to be, Nicholas, very tight. It's definitely diffuse, especially if we go to apicranial. If you look at the diameter even of this diagonal branch here or the circumflex and diameter of the left main, it seems that there is diffuse atherosclerotic disease pattern with really most of the disease in the bifurcation point. Of course, occlusion of the LAD. What we see here also is this short lesion in the circ that probably needs to be treated again if we decide for PCI. But what was your strategy? I'm sure you had heart team discussion, and please share the insights.
Absolutely. I think in this case, the patient is very young, is diabetic, so it's mandatory to discuss this case with the heart team and not to go for ad hoc PCI, of course. So the surgeon decided not to propose him a surgical revascularization, and so this patient was proposed a full percutaneous revascularization by PCI and stage PCI. So as mentioned, because of the result of the MRI, the CTO treatment of the mid-LAD did not make sense, so we decided to focus on the right and the right coronary and the left main. And it's also very important, as mentioned by Jacek, this is a high-risk PCI, so we first have to fix the right coronary artery before starting to the left main. So that's what we did, and we decided to go for a left main PCI guided by RCT, because I think that imaging was, of course, very important to get the best results possible result, and also because we think this kind of distal left main lesion are good candidate for RCT guidance, as we studied in the Lemon trial that we conducted with other French centers, and in which we reported that this RCT guidance strategy was successful in more than 85% of the cases.
But that's fantastic
distal.
result, Nicholas. 86% is really phenomenal.
Thank you very much. So we'll see that if we can do something as successful in this patient.
Okay.
So this is our initial plan, starting with a 6. Yep.
Let me ask you, Gianluca Tiberti is asking, has percutaneous circulatory support device be considered for such kind of case?
Absolutely, and this is always the kind of question that we have in mind. But based on our experiences, which is not the largest experience, but we did some cases with Impella support and without, we think that if the patient has, if the right coronary artery is fully revascularized, it's okay to go without support. If you got occluded right coronary artery, then in this case, I think Impella is important.
Yeah, let's see what OCT showed in this.
Exactly. So we've started with, in this case, with RCT run that is proposed, and I have to admit that we are very lucky because a few weeks ago we received this Ultreon 2.0 system from Abbott, which is an upgrade of the previous RCT system with a nice co-registration features, and that will help my life being easier in the cath lab. And so the first thing that we can see on this RCT run is that it's a very diffuse disease, as you mentioned. And if we go a little further into the details, we see that on the distal part of the left main, we've got a fibrolipidic plaque that we can nicely see here. There is a complete attenuation of the signal from 12 to 6 o'clock, meaning that there is some lipid there. Not a lot of calcium, which means that the preparation will be easier without the request of atherectomy or lithotripsy. Second information is that this lesion is really tight because
it's automatic calculation. Yeah.
It's an automatic calculation of the minimal lumen area at this point, and you see that there is a co-registration. The image that we see here are pointed out on the angio by the red arrow.
Okay.
And it's very precise. And you really know where the image are from the angio. So very tight lesion, 2.7 square millimeters. It's very tight once again. So definitely it requires revascularization. Then we have to think about potential landing zone to put our stent edges. First, to define the proximal landing zone. So this one was selected. It's maybe not the best because there was some diffuse disease, but at least we are able to get EL to EL distance that is 4.1 millimeter, and that will be the basis for the sizing of the stent.
But after predilatation, it may change.
It may change.
As it usually does.
Exactly.
Okay. Yeah.
Second, we are more lucky to get a distal landing zone on the prox circumflex, and in this case that was quite appropriate because you see that you can identify the EL on more than 70% of the circumference, and the EL to EL image distance was 3.5 millimeters. So this is more reliable just to size your stent, and at last but not least, you are able to measure the length between the prox and the distal landing zone, and in this case it was 15 millimeters, sorry. And the other good option with the Ultron 2.0 is that you are able to make some 3D reconstruction online in the cath lab and be able to assess the number of ostia. So this is a real trifurcation. You see that there is 3 ostia, one for the LAD, one for the ramus, and one for the circumflex.
Yeah, with the co-registration again, there is a white dot showing the position. Okay.
Absolutely, you see that we are in the polygon of confluence, exactly where you like to sit. So, to wrap up, these are the information we got from the PCI, the OCT. It's a fibrolipidic plaque. The landing zone to landing zone length was 15 millimeters. The distal landing zone EL to EL distance was 3.54 millimeters, and the proximal landing zone EL to EL distance was 4.1 millimeters. So based on that.
I think we should stop here. There are a few questions that we received regarding mechanical circulatory support. Maybe we can ask Jacek also to comment. One question was whether we should do right heart catheterization to decide whether or not to use support, and the other left ventricular and diastolic pressure. What is your routine practice? We discuss our practice.
This is easy to be performed, especially when you catheterize arteries. You can go to left ventricle and look for left ventricular and diastolic pressure. But for me, it's not a routine to decide on hemodynamic assessment. I rather trust, on angiography, so complexity of the disease that I need to treat, and also, the important issue is the territory of myocardium and risk, and
this
finally,
is chronic heart failure.
If it is chronic or acute presentation, if the patient is hemodynamically unstable, if the patient is with recent myocardial infarction, I would definitely go for left ventricular assist device in this particular case. But here, I believe that we can go without also.
Perfect. Bektash Murat is asking Nicholas, what was the reason of selecting OCT and not the IVUS? And also Yusuf. So people would like to know, in your practice, you are expert for imaging, so you use both.
I use both.
Yes.
I admit. Probably the main reason why I would not choose OCT is the presence of any ostial disease, because I think in this case these are very challenging lesions to correctly identify with the OCT, whereas the IVUS is much more accurate for that. So in this case, I think IVUS was also feasible, but we like to practice both. And also, I really like, in case of trifurcation, I like maybe OCT better because of the potential of 3D reconstruction.
Exactly, to know three-dimensionally.
And especially when we will go for the assessment of the results.
Okay. Jacek, would you agree on this? I know that you are really one of the most experienced IVUS users in Europe. So this is contradiction, maybe OCT or IVUS in this case?
I believe that this is one of the cases that we can do both, IVUS or OCT. Why? Because it looks like the ostium and the proximal part of the left main is not very diseased, so it means we don't need to cover the ostium, and we don't need to look exactly how the stent looks like afterwards.
Yeah.
And this we will discuss during the second case. So I believe that this is good for both. For me, the most important is to use imaging to optimize complex PCI, like left main PCI, and then you can use the method you have the better experience with.
To go back to the smart board, the strategy that Nicolas selected was inverted provisional. What means inverted provisional? It's actually stenting from the left main into the circ. There is already previous stent, but from the left main into the circ, optimization of the result, jailing wires, and then progressively, step by step, making decision about further steps. So what is absolutely necessary based on imaging, we selected diameter and the length of the stent, and then pot. So these are two steps that we have to perform. Can you show us how it was done?
So definitely, once again, I mean, because with the OCT, the choice of the appropriate stent and appropriate pot balloon is easier. So first we fixed the distal circumflex lesion with a 2.5, we pre-dilated and stented with a 3.0 stent. And then we pre-dilated with a compliant balloon, so we don't need really much something stronger than a compliant balloon. And we carefully advance our stent through the left main to the proximal circumflex. The good part is it's not shown on these slides, but you can have a very nice co-registration. You can define on your angio in the cath lab the place of the distal and the proximal landing zone and stick with that, this information.
Dr. Muhammad Waqas Mazhar is asking, do we need to prepare adequately ostium of the LAD and circ? Of course, in your case, circ ostium using cutting balloon or scoring based on imaging?
I would say no.
You say no?
No, because it's fibrolipidic.
Yeah.
And there was no imprint, so that's also a nice feature of the imaging. So we inflated the balloon and went for a pot with a 4.5 non-compliant balloon. We went for something a little larger than the EL2EL, but as you mentioned, the dimension could vary after predilation. And so that's where we performed our first pot inflation. And you see this inflation is it's distal, so...
Yeah, we can see that proximal edge is not covered with the shoulder.
Exactly, and if we use high definition angio on the right panel, we see that there is a bottleneck effect that is related to an inappropriate pot, so we have to go a little more proximal, like this.
Why no wire in diagonal, Yusuf is asking.
Yeah, well, it's... Once again, I'm not sure that the presence of any wire would prevent the potential occlusion, but it's just a personal choice, and we felt comfortable about rewiring in case. So this is a second pot. You see it's more proximal, and I prefer just to get the proximal marker of the balloon out of the stent, very proximal. And then for Dr. Yusuf, we rewired the diagonal, and that's what we got. So
after pot?
After pot. It's just the result after stenting and pot.
Okay.
And in this case, we decided to open the side branch, which is the ostial LAD.
Large diagonal
Yeah, because we found that the diagonal was large and long. It was very long, so it could have some impact on the LV function. And we did a final kissing balloon there, with a 2.5 and a 3.0 balloons. And we went for control.
So after kissing, after optimization, imaging to evaluate the result.
Exactly.
Okay.
And so these are the results. This is our control. So of course, you see that now the lumen in the left main is much larger. We have no signs of under expansion.
Yeah, just for our audience now, with this software, we have from in different direction compared to prior.
Yeah, it's correct.
So
because
we follow angiography.
Exactly. So you see that now it used to be with the previous OCT system, the Aptiview, it used to be from distal to proximal, and the distal section was on the left of part of the image, whereas the proximal was on the right. And now we see that everything has flipped.
Yeah, and there are some dissections that I see.
Absolutely. So we now go over the data. And first, we see on the proximal edge, once again, we got this nice co-registration. The red arrow represent the position of the lens and of the image. There is a minor dissection, and we will go over this detail afterwards. This is the expansion in the distal left main. We see that now the minimal luminal area increased from 2.7 to 9.7 square millimeters. And the software can also give you the expansion, which is 86%, which is correct. Interestingly, in the polygon of confluence, a little more distal, the area was 11.74 square millimeters, so the very good expansion. The distal edge of our left main to circumflex stent was presented no dissection, and a correct expansion of 6.6 square millimeters. What was not good was the aspect on the proximal edge of the circumflex to obtuse marginal branch with here, which is a major dissection. So once again, you can do some 3D reconstruction, which is a very super nice feature on the Ultron 2.0, and the very interesting part is the analysis of the bifurcation and the position of the wire and the expansion of the stent.
The crossing point.
And you can see the crossing point, as you mentioned. Here we, I think, have a very decent result because we see that the wire goes into a cell connecting to the carina that is correctly expanded.
And you also see that with the inflation of balloon, you push some metal and scaffold the ostium. So we see some protrusion of the metal from the stent into the side branch. Yeah.
I think this is an acceptable result.
Yeah.
So the question is, what shall we do now? Do we have to optimize a little more? So what is interesting and what is nice is that we have these PCI criteria that were published 5 years ago, but they are still, I think, a reference, and they can tell you which are the dissections that you can respect or not, what is the expansion that is acceptable or not, and what is the degree of malapposition that you have to correct or not. So in this case, we have a minor dissection on the left main stent proximal edge, and we have to do, according to these criteria, nothing. There is a major dissection on the proximal edge of the circumflex stent, and we have to put an additional stent. There is no malapposition, and the expansion is less than 90%. It's between 80, the minimum, is between 80 and 90%. So we have the option to report on
to October.
So if we stick with the Lehmann criteria, we can say that an expansion over 80% in the left main is correct.
Is correct.
But in October, it was more than 90%, which is debatable.
Yeah. Can you show us, I know that you have nicely prepared some images, the difference between major and minor dissection. I think it's really much
Thank you. Yes.
better to see it here.
So here we can observe a dissection which is there. But shall we correct that? And what we have to assess is different factors. The first is the radial extent of this dissection. It should be, here it's probably 45 degrees. And then second point that we have to assess is the depth of this dissection. And we see that the dissection is limited to the media.
Does not go beyond.
It's not
Yeah.
a very, the depth is very limited. So in this case, it's less than 60 degrees, and we have the limit, the dissection does not go beyond the media, and
Clear.
it's less than 2 millimeters in length. So we can.
And it's inside the left main.
It's
Does
inside,
that-
even if it's inside the left main,
Okay.
I think we can respect that rather than just putting an additional stent on the ostial left main, because stenting the ostial of the ostium of the left main is also a source of potential complication. Here it's very different because we see that the depth is larger. We see that the dissection goes beyond the media to the adventitium, and the radial extent is a little larger. It's almost 60 degrees. Moreover, we also identified on the pullback that the length of this dissection was more than 2 millimeters. Although we are not able to identify it on the angio, I
Yes.
think these are definitely criteria for covering this dissection and fixing it. So
Perfect.
that's what we did.
Thanks. There is a question for you. How you selected the size of balloons for kissing?
Oh, so it was based on the angio for the diagonal branch, and it was based on the size of the stent for the circumflex.
So 2 reference diameters of daughter branches. And there is question actually also for Jacek and myself. Do you recommend us to perform routine KBD for inverted provisional stenting even if LAD ostium is normal? I think depends on multiple. It's optional. There are no data clearly demonstrating the benefit of routine kissing in provisional. We don't recommend it routinely, and probably it's individual case-based assessment. Jacek, anything to add?
Yes, you are right, but when we stand from left main to circumflex and LAD is patent, then the territory of risk is high, and I am much more liberal to do, even if I have a good result, to open stent struts towards LAD, to facilitate possible future procedures. So this is, when I do crossover stenting from left main to circumflex, I am much more open to do the kissing. If I do opposite, which is our routine for majority of patients, that we stand from left main towards LAD, that it depends. For younger patients, big circumflex, I still do it. But if I have a patient who is old or the patient who is hemodynamically unstable and I have a good result on circumflex, I do not perform this.
Yeah, so if I may summarize that, it's not mandatory, but if you do it, there is no penalty for performing kissing also in provisional. Show us how you reacted, because this is really a reaction to imaging.
So, yeah. So we decided to cover, and also because there was still some disease between the 2 stents, we decided just to cover everything with a 3.5 stent. And we reported the left main, which is debatable, with a larger balloon in order to get a better expansion. But at one point we have to think also that we should not try to just treat numbers, but also patients. And that was the final angio result.
Perfect. Let's congratulations. Looks very nice. But a couple of questions. Ramus seems pinched post-stenting. Any consideration given to that afterwards? Muhammad Khan is asking.
Yeah, well, we felt that the option at this step will have been to go for a final additional triple kissing balloon there, but we felt that the size of the ramus was too small and the length was moderate.
So small branch. And Ahmad is asking, if it is dissection limiting to the media, why better not call it intramural hematoma?
Yeah, I agree, but what's I think it is the same kind of affection and disease.
Another question also, do we need to care about ostium of medium-sized ramus? You said you assessed it as really clinically not relevant, not supplying with blood 10% of myocardial mass. So keep it open was the strategy with which I agree. Jacek, any final comments?
Of course, I agree with your opinion about this small side branch. It's pinched, but the TIMI free flow is present, so there is no need to open it. And maybe within the next minutes after nitro, it will be better. The angio result is perfect. What I always do at the end, I do intravascular imaging to confirm.
Yeah, there are several questions. How do you select OCT or IVUS? If you do IVUS, you can probably repeat. What to do? Yeah, Ali Masri is asking if OCT is not available, what should I do? IVUS?
IVUS?
If IVUS is not available, then probably stent enhancement software. And of course, angio-guided optimization. In the recent time, we don't discuss really a lot of technical steps that we learned with time. And I believe that everybody should know, we learned from Gérard Finet, for example, if you do kissing 10 seconds and measure cross-sectional stent area, you get some certain number. Then if you repeat it again just for 10 seconds, it becomes larger. Third time, even larger, because stents are also plastic, elastic, but also plastic. So we need to select properly balloon size, keep balloons inflated for at least 25-30 seconds, repeat kissing balloon inflation, separately high pressure inflation in both ostia. These are really technical steps that maybe imaging can even further improve, but we should not just rely on the image guidance. We also need to perform optimally angiography-guided procedure. And for colleagues in certain parts of the world, of course, with lack of imaging, we need to know, and the European Bifurcation Club will publish an ex-consensus document dedicated to how to optimally perform procedure if imaging is not available. So we will try to put focus on all the steps that you can do in addition to image guidance. And of course, we appreciate image guidance, and for several years, it's part of our consensus documents.
And I think if I might add
a point, please.
I think in my personal experience, the practice of intracoronary imaging also improved the way I treat patients with PCI without imaging, especially in case of POT, because my first cases of IVUS or OCT-guided bifurcation showed me that my POT were not proximal enough, and I was missing most of the time the first millimeter or the first crown that was underexpanded. It's a very usual and very common findings when you're assessing your results, and so based on that, I changed the way I practice POT.
Yeah, there is a question from Jose Manuel Navarro. The repot with larger balloon increases the risk of proximal dissection.
Correct.
Yeah, and the clinical question that is really relevant from Vimal. In our case, CMR has told that the LAD territory is not viable. In cases where thallium shows no viability, we are advised to assess viability with PET scan. Comments regarding sensitivity and specificity of cardiac MRI for the viability. I think it's a gold standard also.
For me, it's a gold standard. It's also the most available option in my institution.
Tool. Okay, great case. Thank you very much, Nicolas. Just the highlights of the October you nicely put at the end of your presentation.
Thank you. I think that the October was a prospective randomized trial that compared a strategy of OCT guidance versus standard angio guidance for complex bifurcation. And I would say the main results are in terms of clinical events, the OCT guidance showed superiority over the standard approach with fewer events over the first 2 years, and that were potentially driven by not the most complex, but the most simple cases, the one-stent stent, which is rather interesting because sometimes you think that it's simple, you can do by angio, but obviously OCT provides you advantages, even if it's simple, and non-calcified lesion. And so I think it was, I think that we might forget about the Renovate complex PCI trial that mixed IVUS and OCT, but show once again that the superiority of imaging guidance for left main lesion.
Yeah, the subgroup of left main was the strongest,
exactly.
Actually.
So before ending up to Jacek, I think that OCT guidance for left main is feasible, it's accurate, and it might improve prognosis. Very simple. Thank you.
Thank you, Nicolas. Sorry, we go back to you. Yes.
Yes, so now we switch to another case. And this is now the 70-year-old gentleman who was first treated with PCI on May this year. And it was PCI of the CERG with DES implantation. Left main was assessed as the borderline stenosis. LAD was not treated. Ejection fraction was preserved. Patient was sent home. Unfortunately, a few months later, in October this year, he experienced ST elevation acute MI complicated by cardiogenic shock. And this time he was treated with primary PCI of LAD. He was in a poor condition. Left ventricular ejection fraction was assessed as a 15% with severe mitral regurgitation. Fortunately, patient survived this, and of course, the angio revealed also this left main stenosis, which this time was assessed as the 70% stenosis, trifurcation lesion, Medina 1101. The patient was discussed at the heart team meeting and was turned down from surgery because of the high risk and was scheduled for PCI, and this time definitely with left ventricular assist device with Impella support. So we staged this procedure. We admitted patient to our hospital again a few weeks later, now in relatively stable condition. Fortunately, renal function was preserved. LDL cholesterol was close to the current target, and NT-proBNP at the level of 1500, so not so bad according to what we have seen few weeks before. And there was also some improvement in left ventricular ejection fraction, and you can appreciate this 25-30% ejection fraction. However, still moderate to severe mitral regurgitation was present. So taking all into account, mitral regurgitation, recent acute MI, low ejection fraction, we still kept this strategy of doing left main PCI with Impella support. And this is the angio of this patient. You can appreciate distal left main stenosis. And by angio, to be honest, for me it was also ostial LAD lesion and ostial CERC. I was not really sure about this, what could be intermediate branch or maybe first diagonal or first obtuse marginal by angiography. It is difficult to say. However, still we have complex distal left main disease in patient who is hemodynamically, let's say, unstable. And of course, the question is how to proceed with such procedure, even with Impella support on board.
Yeah, if I can again go back quickly to analysis of these two baseline angiograms, it's definitely more severe presence of disease compared to case that Nicolas showed. Definitely, I agree with you 100%. If these still frames correctly represent the nature of disease, it's distal 111, maybe even trifurcation with this high origin of intermediate branch. There is definitely some disease present in front of the ostium of the CERC, and we know, again, we applied the same lateral wall, most of the plaque, according to imaging, in front of the ostium LAD, so predominantly disease pattern in front of the ostium of the LAD, distal left main, and some plaque also present in the distal left main in front of the ostium of the CERC. But I know that you did IVUS, so tell us how IVUS is in agreement with this angiographic interpretation.
Well, this is our routine for many years to perform left main PCI, especially complex left main PCI with intravascular ultrasound, and we usually do pre-interventional imaging to assess plaque distribution, appropriate assessment of sizes of the all part of bifurcation. And we started with LAD. You see this stent implanted a few weeks before during primary PCI. Very well expanded and probably the good size. However, did not cover all the plaque. We see on the proximal edge still a lot of plaque, more than 50% plaque burden, and going more and more proximal, we see it more. And we also see very tight stenosis in the distal left main. There is also plaque all along the left main up to the ostium, which is very, very important for me to plan the procedure. This is the circumflex pullback, and again you will see the stent which was implanted on May. And again, we can say that the procedure was performed appropriately. The stent is well opposed, the stent is appropriately sized. But what is for us most interesting is what happens proximal to the stent. So we will see in the second, now you see the proximal circ, the intermediate branch. And what is interesting, there is no tight stenosis there in the ostium. For me, now it's a little bit different because I thought in the beginning that we have, as you said, Medina 111. We are not sure about the intermediate branch.
Yeah.
According to angio assessment and the size of the stent implanted before, I assessed LAD as a 3.5 vessel, circumflex 3.0. So according to Fine rule, left main should be around 4.5, maybe 5.0. In the proximal part. However, after this assessment, we can see in LAD that it is bigger vessel, at least 4.0. We can appreciate that the plaque burden is present all along the proximal part up to the stent, and we see also in the ostium negative remodeling, and this is very important, and not to exceed too much negative remodeling with your balloons. Fortunately, media-to-media diameter was 4.0, so still it was, for me, possible to use 4.0 stent instead of the smaller one and get the room for over-expansion of the stent in the left main, which is very important. Distal left main, tight stenosis, around 5 square millimeters there, and also the plaque in the mid part and protruding up to the ostium, which is very important because now I'm really sure that I need to stent all the length of the left main. And what is very important, we have not so much disease in the ostium and proximal part of the circumflex, which at the end changed my assessment, because now I see that this is Medina 110. This small branch is not the intermediate, but very large obtuse marginal, and we have larger vessels, 4.0, 3.5, and the left main is 5.5. So maybe we can
definitely
the minute to
change.
discuss if it's changed our strategy, because based on angio and without intravascular imaging, in this patient who is also high-risk patient, I will be probably much more flexible to use upfront two-stent strategy to be on a safe side. But now maybe we can change the strategy.
Let me ask you, Valentin Krastev is asking why left main was not fixed during primary PCI.
This is a very good question. However, I would like to remind you the results of the culprit shock trial. Then if you do in patients with in cardiogenic shock, all the lesions you see, you increase actually survival and not improve survival. They were concentrated on the culprit lesion. And taking into account what happened afterwards, the decision was appropriate. However, maybe it was a good option to use left ventricular assist device in the acute phase of MI. However, this is also not proven yet by good randomized data. We wait for this data. They will be released in the spring 2024.
Exactly. Ahmed is asking, in left main stenting, some operators prefer to cover the whole left main in the absence of imaging to avoid complications. What do you think?
To be honest, this is the strategy that I follow in majority of patients, unless I have really the big left main and the stenosis is really in a distal part. Because I do not like to position the proximal edge of the stent in the left main in the big plaque burden.
Yeah. Piotr Pavluchuk is suggesting provisional stenting left main to LAD with just POT. Dr. Narayanan is asking whether LCX ostium seems to have high plaque burden, even though lumen is good. Does that concern when considering provisional stenting strategy?
With this IVUS evaluation and some shadowing of the wire, it's not necessary. It's not possible to fully appropriately assess this ostium. But I believe that this plaque burden in the ostium is not so much. The lumen area which we calculated was at the level of 4.5 or even more, and the plaque burden was less than 50%. So I believe that this is not an issue that we need to immediately go for two-stent strategy.
Please go to provisional strategy and show us the steps.
So, taking into account some calcifications, negative remodeling in the
And 3 wires, which I really admire a lot.
in the ostium, I decided to predilate, of course, and we have used 3.5 non-compliant balloon, and afterwards in the left main, even 4.0 cutting balloon. The length of the stent was also assessed by the IVUS pullback, and this was 28 millimeter
What
long.
are the criteria for landing zones, just for our colleagues?
In this case, for me, it was necessary to stand to overlap with the previously implanted stent in LAD by 1 millimeter and then go
and
up to
cover
the
the ostium.
And
And
it
this is the
was
projection.
assessed as the 28 millimeter long stent, 4.0 in diameter. This is the stent implantation. And you can see this contrast injections. We are just in the ostium, maybe protruding 1 millimeter.
Can
to
I
the
stop
aorta.
you for a second? There was a beautiful question of Yusuf during your presentation. What about pot puff if IVUS or OCT are not available? So please explain what is a pot puff. It's a fantastic, simple method to evaluate.
Technique is was previously described by Jean Fajadet as IVUS for poor people many years ago, and we try to check with this if the size of the stent is appropriate. However, if you stent from the ostium, if you have a plaque there, so sometimes you undersized because the stent is a post, but it doesn't mean that it is well expanded. So, of course, it can be used, but if you have the proximal part of the vessel which is not stented.
Is there a risk of using the IVUS when critical left main lesion, as it may interrupt the flow before the predilatation? Is it risky?
It is, it depends from patient to patient. If you use solid state probe, you can do it because then the time of flow limitation is relatively low. With mechanical probe, when you leave the sheath distal, it takes longer, so it means that it can be the problem. But you can always use the undersized balloon, predilate, and then it becomes safer.
Yeah, and the last question before you proceed, again from Ahmed, do you prefer LAO cranial or AP cranial for left main ostium delineation?
To be absolutely honest, for me still, the positioning of the stent just in the ostium is the most difficult part of the procedure.
Can you explain
we usually use and
what
only
we see
use
on this image?
This is epicranial, I suppose. This is not LAO cranial. And here we can see that the upper part of the stent is just at the conjunction of the left main with aorta. So it would always protrude on the lower side because it is not perpendicular origin of the left main. So usually we protrude a little bit. This is very difficult. Sometimes we spend a lot of time and use multiple projections from LAO cranial to AP cranial. I believe that in the future we will use more and more often computed tomography, coronary angiography, CTCA, and we will plan this based on CCTA, then choosing appropriate projection. It would be much more easy in the
Okay, next slide.
This is what we checked. Of course, after implantation of the stent, we need to do POT, and this was the plan. And sometimes I see that operators, if they see such pinching of the circumflex, it was of course caused by carina shift with this negative remodeling, they try to immediately rewire, which is very dangerous. You very often rewire abdominally. So definitely, even if you see such stenosis, this patient became a little bit symptomatic with some STT changes, but I continued with the POT. This was very, very important. First, we need to oppose the stent to the vessel wall. It was 5.0, actually 5.0. 5.0 balloon and dilated, as Nicola mentioned before, all the length of the stent. It is very important. And afterwards, of course, we need to rewire. Some people say that if the wire is going with the loop, you are always good. I do not believe in this, because I have seen many times that the wire can go through the stent struts abdominally. So my practice is that after this, after I put the wire into the LAD, I do imaging.
Okay.
And then I can check the result.
If I understand correctly, so you wire, trying
Yeah.
to wire with the loop, but immediately you go with the
I
IVUS
check
probe.
this with IVUS. And then I am always only sure if I am going appropriately through the stent into the LAD with
So
my wire or abdominally.
You confirm that there is no abdominal. And it's not rare. In the October, 10% of cases, in the left main, 20% of cases. So 1 out of 5 in October, if I'm correct, had the longitudinal unintentional
stent
wiring,
distortion.
Stent distortion.
If
So
you do not recognize this abdominal
This is
wiring and you
fantastic.
continue
Yeah.
with the procedure, you can get
you
into
have
real trouble.
IVUS probe is already
Yeah.
there.
Yeah.
1 minute. You go inside.
And then you, the same time, you check if you covered the ostium, if the stent is already well expanded.
Perfect.
If you need
Pot
to
is
post dilate,
done, exactly.
everything is
Perfect.
is in place. So it's very easy. It takes like 1 minute.
Okay.
And so I see here very good lumen in the distal left main, which is
13, yes.
13 square millimeters, but the size is not enough.
Okay.
Because we assess this vessel as more than 5.0, so it means that we really need repod with probably bigger balloon. This is also from this. And of course, doing this, we also check for possible, as you mentioned, stent deformation is a real problem. We know this from Excel. It was found in 6.5% of
Yeah.
procedures performed with intravascular imaging guidance.
Yes.
Even this was overlooked by operators, and the follow-up was not so perfect. And in fact, stent deformation was the independent predictor of poor outcome. So this is, I believe, very important. And of course, I rewire after checking. I rewire going from LAD more proximal and try to find the distal strut. And with IVUS, it's not so easy to check if it is distal or not, like we can do with OCT.
Yeah,
So
but
I use
geographically
two
looks
projections. I
really
usually tap,
very
yes.
close to Carina. Yeah.
And I use 2 projections, and after rewiring, of course, we need to post-dilate. I opened the balloon, 3.5 balloon in the LAD. I did a kissing, 3.5 and 4.0 in the LAD. Very important to do the mini kiss, so very short overlap of the balloons, and of course afterwards kissing, and this is the result. And this result doesn't look so bad. However, still we see some haziness in the ostium of the circumflex, so it's not
In
perfect.
the outer
It's not
part.
perfect, and some can have a problem. Some operators can have a problem. What to do now? Maybe immediately go for another stent. I had different approach. First, I checked with intravascular ultrasound. And this is the image. Again, we are in a stent which was implanted a few months before. But when we move to the proximal part, it doesn't look so bad. We have quite good lumen. However, we have also this wire shadowing in the ostium, which somehow make this assessment, this appropriate assessment, not fully reliable. So this is why in this high-risk patient, I decided to continue with assessment. Lumen area was 4.5, but I wanted to be really sure that I don't need to implant another stent. And I use microcatheter-based physiology assessment, very easy.
Fantastic.
Again, 60 seconds, and I measure there is no gradient, no significant gradient. It's 0.93, 92 of non-hyperemic parameter. And if you do the pullback, this 0.07 of gradient is diffuse and not in the ostium. So this confirmed for me that I can continue with provisional strategy. However, we touched the ostium of the circ, we touched the stent which was implanted a few months before, so I decided to optimize this with a paclitaxel coated balloon for the proximal part of the circ. So this is paclitaxel.
After lesion preparation, DCB?
DCB 3.5 by 20 to cover all the damaged part of the vessel which was touched with previously with balloons. And again, kissing 3.540, and at the end 5.5 pot, which was not recorded, but I
but we see
did
the
it.
position.
Yeah, I did it after this first check with IVUS of the stent expansion. This is what we have achieved. Even by angiography, the result is much better, I believe now. And maybe this is because we performed repeated dilation in the circ, prolonged dilation with
DCB,
paclitaxel-coated balloon. But of course, we have checked this with intravascular ultrasound, and this is a small trick. Still, you can see this wire shadowing, which is also present in OCT. It was difficult to assess, so this is why the result was good. So I decided to remove the wire, and now the pullback is much better to be assessed because there is no more wire and there is no more this wire shadowing. So we can check what we have now in the proximal part and in the ostium of the circ. It looks like there is some small plaque burden there, but the lumen area is 7 square millimeters, and for me, I believe it's much better than to implant another stent. Of course, at the end, we did a pullback also from LAD to left main, and this is what we have achieved in the left main. You see the in-stent area is much bigger, the ostium is covered, and the stent is really big one. We need to calculate. This is still much more easy with OCT, with automated calculation. Here we need to measure, but it is not very time consuming. Stent expansion in LAD was more than 90%. Then we assessed this stent expansion in the left main, and this is also important to stress. The stent expansion was 77%, so even before 80% cutoff, which was in the October trial. But we have to keep in mind that left main sometimes is tapered vessel, and you will never achieve more than 80%. We have lumen, which is 18 square millimeters, 5 millimeter more after this repot. And we have also good lumen in circ. There is no stent in the ostium, so we do not calculate what is the stent expansion.
Yeah, show the data because we are almost at the end.
This is just the short summary. They are very important. For many years, we have shown this meta-analysis performed by Gary Means and co-workers, showing us that if we use intravascular ultrasound in left main PCI, we decrease mortality, we increase survival, we decrease the risk of stent thrombosis. Of course, the critics told us that this is only meta-analysis of registries. Some people say that if you are experienced, you can do it without IVUS with the same quality. However, data from the British registry are telling opposite, that for those procedures performed by most experienced operators, maybe the same time more complex procedures, there was the biggest advantage of using IVUS in according to mortality. And we have 2 randomized trials mentioned before, Renovate Complex PCI October trial, and we have this large meta-analysis of all randomized trials comparing angiography with intravascular imaging, either IVUS or OCT, when we can appreciate not only the lower risk of revascularization or stent thrombosis, but also all-cause and cardiac mortality. And this was mentioned before, doesn't matter if we use OCT or IVUS, if they are both good enough for particular patient, but the most important is to use it in complex procedures.
Bravo. Congratulations, really excellent, 2 fantastic cases. Few questions. Left main always stent with more radial force, such as Megatron. I think that nowadays new generation stents have similar radial force. What we would like to achieve for the left main is having stent with expansion capacity. That is also extremely important parameter, and size of the side branch opening as well. How to calculate atmosphere limits of simultaneously inflating these 2 relatively large kissing balloons? What pressure you use? With kissing, you don't need very high pressure. You go separate high pressure, but then simultaneously go to moderate.
Absolutely agree, especially for provisional strategy. We don't often exceed like 8 to 10 atmospheres on both balloons. The exception is the kissing balloon after 2-stent strategy. When I have 2 stents, I usually use at least 1 kissing with larger pressure. But this is my
Fantastic. This is unfortunately the end. I really thank you both for fantastic cases, very well prepared. I thank our audience for so many useful questions and for sharing the insights in image-guided bifurcation PCI today, left main PCI. I'm really sharing very positive feeling and attitude that with new data and new software, which is really simplifying action based on imaging that you register, we will achieve better PCI result and we will improve further outcome of our left main patients. Thank you both. Thank you to Medtronic for setting up this series of bifurcation webinars. Next one will be sometime in maybe March or February. We will see what are the available dates, and then we will again open another important topic like the role of DCB and other new technologies, use of physiology. This is another direction. In addition to imaging, there are new tools and technologies to further optimize the results. So having said all this, I really thank you for such kind support to Bifurcation Continuum, and I'm looking forward to seeing you soon. Bye-bye.
Thank you.
Thank
very
you.
much.